Hello everybody, this is Dr. Gopi. Today it is session 6 of ICU Nursing Orientation Program. The topic today is ECG Basics, Arrhythmia and its Recognition. Know the rhythm and save the life. Let's discuss deep into the topic in this lecture. The learning objectives today. Placing the ECG leads correctly. There are 3 different lead systems that includes 3 leads, 5 leads and 12 leads system. Avoid commonly making errors while placing the leads. Identification of normal sinus rhythm. Recognizing the 6 features of normal sinus rhythm that includes rate, rhythm, P wave, PR interval, QRS wave, ST segment and T waves. Recognizing the life-threatening arrhythmias that includes ventricular tachyarrhythmia, ventricular fibrillation, asystole, pulseless electrical activity, complete heart block, fast atrial fibrillation, and related arrhythmias. Escalating these concerned arrhythmias or abnormal rhythms correctly and informing the concerned persons that includes resident doctors or duty nurse or routine documentation as per the severity of the rhythms. Lead placements. As we already discussed, there are 3 different lead systems are available. First is 3 lead system. Here, as the picture depicts, right arm is placed just below the right clavicle, that is red color, and left arm placed just below the left clavicle, and that is yellow color, and the left leg is applied over the apical area. And in the 5 lead system, the RA is white over the right arm, LA is black over the left arm aspect, green is the right leg, red is the left leg, and V is the brown vertex. So this will show us lead 2 rhythm and V1 ischemia and RB/VB in ectopics as well. 12 lead system, as we already discussed, it is as similar to the ECG 12 lead ECG system. How to read any rhythm? The 6-step method. Use the same sequence every time. You won't miss anything. First, look at the rate. Count the R waves in 6 seconds and multiply into 10, or the ECG itself shows us the rate, but you should know how to calculate it. The number of normal rate is between 60 to 100. Less than 60 is bradycardia, more than 100 is tachycardia. And you can measure the small squares and large squares also in between the RR interval. That we'll discuss in another lecture. Next is rhythm, whether it is regular or irregular. And the RR interval is again used if the RR interval is uniform, that is regular. If it is not uniform, then it is irregular. If it is irregularly irregular, the most proven single rhythm that is characteristic of irregularly irregular rhythm is atrial fibrillation. Next is P waves, whether it is present or absent. If it is present, it can be a normal or any other abnormal rhythms. But if it is not present, then it may be due to atrial fibrillation or atrial flutter or junctional rhythm or ventricular tachyarrhythmia as well. Next, the PR interval. The normal PR interval is 0.12 to 0.20 seconds. That is equal to 3 to 5 small squares in the ECG, in a standard ECG measurements. If the PR interval is long, then it is first degree heart block. If the PR interval is variable, that may be due to second degree. If it is dissociated, which means the P and QRS doesn't have any correlation, then it can be a third degree heart blocks. In QRS, the narrow QRS less than 0.12 second is normal. If it is wide, it may be abnormal, can result in ventricular or SVT with aberrant conduction. It can be narrow in supraventricular origin as well. And ST and T segments, normal or changed. You have to check. ST elevation, it can be a STEMI, which is ST elevation MA or pericarditis. The ST depression is there, then it can be due to ischemia. And peaked T wave, hyperkalemia, inverted T wave, ischemia or strain pattern. Now look at the sample rhythms of each variety. In a normal sinus rhythm, you will get to see the normal P wave and PR segment and QRS and ST segment and T wave. Sometimes you may be seeing the U waves as well. So in this ECG, first in the 6-step assessment pattern, we will look at one by one. So it is a normal ECG. Here the rate is 60 to 100. It's normal rate first. Next the rhythm. It is regular because RR interval is equal. The rate may not be accurate here because of this graphical misrepresentation, because we have to measure the squares between these and divided by the RR interval space. So that we will discuss in the detailed ECG manual in another session. Now in rhythm it is regular because all the RR interval is equal. Next the P wave, it is normal and upright before the QRS segment. Next the PR interval, the space between the P wave and QRS wave, that is PR segment. In QRS wave it is narrow and it includes the Q, R and S. Next the ST segment area is this, and then the T wave. Some cases there will be U waves as well. In atrial fibrillation you can see the P waves are not clearly visible and there are some fibrillatory baseline waves is visible, and the RR interval is not at all uniform. So each RR interval has its own variations because of the fibrillating atrium. And irregular RR intervals, narrow QRS complex, and if it is less than 110 it is controlled, and then if it is more than 110 it is rapid ventricular rate, and if it is less than 60 it is slow ventricular rate. The nursing action, so you have to check the pulse, confirm the rate, don't just trust the monitor, check the vitals and record a 12-lead ECG, inform the doctor and consider rate control anticoagulation measures. If it is unstable AF, which means the low BP, chest pain, altered mental status associated with unstable AF, prepare for synchronized cardioversion, that is shock delivery aspect. And this is ventricular tachycardia. Here you get a wide bizarre QRS complex which is more than 0.12 seconds, and rate ideally will be more than 100 to 250, usually regular. You can see the regularity of RR interval and no discernible P waves or AV dissociation. There is no visible P waves here, and if it is similar wave pattern continuously repeating in order, which can due to monomorphic as same shape, and sometimes the shapes may be different in each waves, or it can be called as polymorphic. Action, so it is in one of the emergency rhythm. Check the pulse first. If it is pulseless VT, then call code blue immediately, start CPR, defibrillate with 200 joules of biphasic synchronized cardioversion. If the pulse and BP is unstable, then synchronized cardioversion. If the pulse and BP is stable, then give amiodarone 150 mg IV bolus, record an ECG, send electrolytes, potassium and magnesium, etc. And this is a ventricular fibrillation. Here the waves are chaotic and irregular waves, and irregular RR interval can be seen. No discriminable P, QRS or T waves at all, and there is no question of RR interval here. And in coarse VF early, fine VF later can be possible. The patient become unresponsive, no pulse, no breathing is definitive. Verify by checking the patient, not the monitor. In case of action, it is a shockable rhythm. Call code blue immediately. VF arrested bed. Start CPR 30:2 compressions is to breath rate at the rate of 100 to 120 per minute, the depth of 5 to 6 centimeter. Attach defibrillator. Shock 200 joules biphasic and 360 joule monophasic. Resume CPR immediately in 2 minutes. For 2 minutes. Adrenaline 1 mg IV every 3 to 5 minutes. After third shock, amiodarone 300 mg IV is the protocol. Next rhythm is asystole and pulseless electrical activity, which is non-shockable. So cardiac arrest without shockable rhythm, here you have to focus on high quality CPR and reversible causes. Asystole is nothing but a flat line. In PEA, pulseless electrical activity, there will be some rhythm in the monitor, but there will not be any pulse. You find and fix all the 5 H's: hypoxia, hypovolemia, hydrogen ions, which is acidosis, hypo or hyperkalemia, and hypothermia. Another 5T that includes tension, pneumothorax, tamponades, toxins, thrombosis pulmonary, and thrombosis coronary. So these are the measures that we have to take, and these are the reversible causes of cardiac arrest of 5H and 5Ts as per the ACLS guidelines. Next, we see the AV heart blocks. This is a graphical image. This may not be accurate, but in first degree AV block, as we discussed earlier, the characteristic includes long PR interval, which is more than 0.2 seconds with 1:1 conduction. Usually benign, just monitoring is the actual routine. In type 2, there is two different class, Mobitz 1 and Mobitz 2. Mobitz 1 has a progressive PR lengthening followed by drop to beat, usually nodal and benign. Here the action includes observation and atropine if symptomatic. Second, Mobitz 2 includes the constant PR interval, which may or may not be prolonged, but sudden drop to beat, which may be due to infranodal. The risk of progression is crucial. Doctor review is urgent. Patient may need pacing as well. And in third degree complete block, there is no relationship between P and QRS. Often slow, wide, and risk of asystole is crucial. The immediate action is it's an emergency. Give atropine if the rate is less than 40, and pacing pads, keep the pacing pads on code if there is any syncope. When to escalate? The decision tree. The rhythm changes are common. Knowing which one needs what response is a skill. Code blue immediately rhythms are VF ventricular fibrillation or pulseless VT, asystole, and PEA. The action includes calc load, start CPR, defibrillation if the rhythm is shockable, and don't wait for the doctor. In urgent scenario that includes the doctor and pads requirement, rhythms include sustained VT with pulse, symptomatic bradycardia, third degree heart block, fast AF with low BP. The action includes residence at bedside in minutes, pacing the pads on, the crash cart ready. The prompt informed doctor scenario includes new AF or flutter, Mobitz 2, frequent PVCs or VTs, ST elevation or depression. The action includes informing the residents the shift and 12-lead ECG trend monitoring. The routine documentation rhythm includes sinus bradycardia or tachycardia, which may be or may not be symptomatic, and primary AV block or first degree AV block, and occasional VPCs as well. The action includes documentation, continue monitoring, mentioned in handover. The session 6 ECG key takeaways that includes apply the leads correctly. So the right side and red, left side and the yellow, and the apex is green. 3 lead system and the 5 lead system as accordingly. If we place the wrong side, then the diagnosis may be wrong. Use the 6-step method for every strip: rate, rhythm, P wave, PR segment, QRS waves, ST segment, and T waves. Always check the patient before the monitor. Artifact and lead off can mimic deadly rhythms. Shockable rhythms are ventricular fibrillation or pulseless ventricular tachycardia. Immediately proceed with defibrillation with CPR. Non-shockable rhythm includes asystole or pulseless electrical activity. Immediately start CPR and look for reversible causes of 5H and 5Ts. Sustained VT and the pulse needs urgent action. Stable patient can be treated with amiodarone. Unstable patients needs synchronized cardioversion. Document the rhythm strip with date, time, patient ID, and your interpretation in the notes. This is the quiz session for the today's discussion. It includes 4 MCQs. Pause the video here and please give your answers in the comment section. I'll be looking forward to see the answers in the comment section, and thanks for watching fully. Next session of section 7 includes hemodynamic monitoring, arterial line, CVP line, and inotropes, etc. Thank you. Bye.